My name is Dr. Amanda Nizam. I'm a genitourinary medical oncologist at Cleveland Clinic, and I'm here today with Dr. Michiel van der Heijden from the Netherlands Cancer Institute to discuss his abstract on the EV-302 outcomes in EV plus pembrolizumab versus platinum-based chemotherapy and the cisplatin-ineligible population, and we will also discuss the results from the cisplatin-eligible population. Welcome, Dr. van der Heijden.
Thank you.
Thank you. So could you tell us a little bit about this analysis that you did in the cisplatin-ineligible population from EV-302?
Yeah, so let's, if we go back to the EV-302 study, it's a study that randomized patients, untreated metastatic urothelial cancer patients to receive either standard platinum-based chemotherapy, which could also be followed by maintenance IO, versus enfortumab vedotin plus pembrolizumab. The results were presented at ESMO last year and published in the New England Journal of Medicine and showed a substantial improvement in overall survival and progression-free survival. So platinum eligibility has defined treatment choice already for many years, for decades actually, and what we did in this analysis is that we separately looked at the cisplatin eligible and ineligible population. So I presented the ineligible population. And this is historically a group with a high unmet need because patients who cannot receive cisplatin usually have worse outcomes. What we saw in this subpopulation is that the outcomes were really consistent with the overall study results. So again, EV plus pembrolizumab was substantially better. And actually in this population, the hazard ratio was 0.43 for both PFS and OS. And I think another very interesting feature and very spectacular actually is that the overall survival, the median overall survival in this group of patients for EV pembro was not yet reached.
And then in terms of the cisplatin eligible population, did you find similar findings in terms of cisplatin ineligible and cisplatin eligible patients in this trial?
Yeah, so again, the overall results of this analysis, which was presented here at this ESCO by my colleague, Dr. Betke, were very consistent with the overall population. So again, a substantial improvement in overall survival and progression-free survival. We did see, as expected, that in this subgroup of patients, the control arm, so the platinum-based chemotherapy, performed a little bit better. But still, the hazard ratios were still around 0.5 and were very consistent with the overall population. So again, significant improvements.
And then with data that has been presented by the Checkmate 901 trial, which we were also involved in, so for patients who have cisplatin-eligible disease now, where both regimens are available, how do clinicians choose between patients who are cisplatin eligible, whether to use gemcitabine or EVP? As you know, there are differences. One has more finite duration of chemotherapy. The other one has indefinite for now. So how do you choose as a clinician in patients who are cisplatin eligible?
Yeah, so it's first of all, I think we should still celebrate that after years of only platinum-based chemotherapy as first treatment, we now have two treatment options for this group of patients. If you look at the magnitude of benefit of these two treatments, I think it is fair to say that EVP looks a bit better. And in the guidelines actually that we made with ESMO, we were very early and already incorporated, actually before even EMA approval, incorporating it into the guidelines. So there we say that in patients who are in places where both treatments are available and possible for these patients, that EVP is the preferred treatment. However, there's other choices that may go into this. There is, and if you look at this from a global perspective, there is of course the toxicity profile, the duration of therapy. I think patients with EVP have to come in a little bit more than patients who would get cisgem-nivo. Financial concerns may also, play a role in these choices, and these are global realities, especially outside of the US. I think also we today saw very interesting data from Dr. Gelsky, which was a sub-analysis of the Checkmate 901, and there we saw that patients with lymph node-only disease actually do really well on cisgem-nivo and have excellent outcomes. So I think for this group of patients that may be something to consider.
Yeah, and that's a very important point I was going to ask. So are there any planned analyses in EV-302 to look at those subgroups who have very limited disease with those favorable prognostic factors like lymph node only disease? Because obviously having a finite duration of chemotherapy would be more appealing to someone with that low burden of disease that may potentially not need over treatment.
Right, so in the ESCO GU presentation of EV-302 that I myself presented, we looked at the subgroups and also at the lymph node only subgroup. We found that this subgroup does really well. This was mostly in terms of objective response rate, but also in clinical outcomes looked really good. I think the objective response rate for this group was 70% or plus, or a little bit higher even. And I think that the PFS was not even reached in that group yet. However, we should keep in mind the Checkmate 901 had a follow-up of almost 3 years, median follow-up, and for EVP it was about 17 months median. Now I expect that the later data will be in line with the curves we have seen, but you know, we have to get a little bit more information to see what the long-term outcome is in either treatment in this group of patients, and I'm sure that will come in the next few years.
Very good. So potentially a role to further optimize therapy for these patients with lymph node only disease.
Yes.
So very good. Do you have any other big takeaways from your data presented here at ASCO this year?
Well, I think what we're seeing now is that the EVP data, of course, it has already come out, but you know, it's such a great improvement in our field. I think we'll continue to see subsequent analyses as we did at this meeting, showing that it is really consistent. And you know, it's almost boring to not have anything, you know, any differences between groups, but it's just a testament to how good this treatment works, that it is so consistent. I think there were some interesting things here at ESCO, for example. We've seen some quite remarkable Chinese data on neoadjuvant treatment with disitamab vedotin and IO, which I think is very interesting. And of course, the treatments that now have shown such good outcomes are being tested in neoadjuvant space, and that's just going to be the new wave of hopefully big improvements.